Welcome back to the Best PT Podcast. This is episode 3.14 talking about traumatic brain injury or TBI. Different types of TBI caused by open head injury, which is direct penetration through the skull into the brain, or closed head injuries, indirect brain injury without skull penetration. Primary brain injuries can be coup lesions, where a brain lesion is directly under the point of impact, whether open or closed head injury. There is also a counter-coup lesion, which is injury to the opposite side of the brain due to the rebounding of the brain inside the skull. So I think of a whiplash type injury in a motor vehicle accident, where the head is snapped back and the brain, although the force comes from the anterior portion of the skull, the brain slams into the posterior portion of the skull and you actually have posterior brain injury. There are also secondary injuries for TBIs, including epidural hematomas, subdural hematomas, hypoxia, ischemia, increased intracranial pressure, and post-traumatic epilepsy. When talking about TBI, we discuss different levels of consciousness. So coma. A person is unconscious and unresponsive to all internal and external stimuli. Stupor. Arousal occurs only with repeated stimulus. Obtundedness or obtundity. Considered to be a state of sleep with reduced alertness and delayed response to stimuli. Delirium is classified as a disorientation, confusion, agitation, or excessive loudness. Clouding of consciousness is when a person demonstrates quiet behavior, confusion, poor attention span, and delayed responses. And then finally, a person is said to have consciousness if they are alert, aware, and oriented, and possess a normal memory. Different types of TBI tests and measures, as well as staging. The first is the Ranchos Los Amigos levels of cognitive function. These go from grade 1 through grade 8, or I should say level 1 through level 8. Level 1, no response. The person appears to be in a deep sleep and does not respond to stimuli. Level 2, generalized response. The person is inconsistent and gives non-purposeful reactions to stimuli. Their responses are limited and often the same regardless of the stimulus. Level 3, localized responses. The response may be specific, but often an inconsistent reaction occurs. The person may be able to follow simple commands, but inconsistently and in a delayed fashion. Level 4, the confused, agitated state. Their behavior is best described as bizarre. Their verbalizations are incoherent or inappropriate. They cannot discriminate between people and inanimate objects. Their attention span is very brief. They lack both short-term and long-term memory. Level 5, confused appropriate stage. The patient can respond to simple commands consistently, but their responses are often random or inappropriate to complex commands. They are highly distractible, and their verbalization is inappropriate. They begin to display some evidence of short-term memory. Level 6, the confused appropriate stage. Patients begin to demonstrate goal-directed behavior, but are dependent on external direction. They begin to show carryover for learned tasks, especially self-care. Long-term memories begin to emerge with more depth and detail. Level 7, the automatic appropriate stage. The patient appears appropriate and oriented. They can go through their daily routine automatically, although they are best described as robot-like. And they are beginning to show signs of carryover learning for new activities, but very slowly. Level 8, purposeful appropriate stage. The patient can recall and integrate past and recent events. They show carryover with new learning, however, they are not considered normal. They still show a reduced tolerance to stress, abstract reasoning, and judgment, especially in unusual or emergency situations. Another type of TBI tests and measures is the Glasgow Coma scale. It is a scale from 3 to 15 points. Less than 8 points indicates a severe brain injury, and possible coma. 9 to 12 points indicates a moderate brain injury, and 13 to 15 points indicates mild brain injury. This scale assesses eye-opening ability, motor response, and verbal response. And finally, a few types of memory impairment. Anterograde memory is the inability to create new memories. Post-traumatic amnesia is defined as the time between the head injury and when the patient is able to once again recall recent events. The patient cannot usually recall the injury or the events between the injury and this point in time where they begin to again recall recent events. And then retrograde amnesia is the inability to remember events before the head injury. This may decrease with recovery. That's it for episode 3.14, talking about traumatic brain injuries, or TBI. Episode 3.15 will talk about spinal cord injuries, SCI. As always, the outline will be in the show notes. Thank you for joining me.